So a very warm welcome to all of you. Thank you so much for joining us here today, and greetings from ICMR Bioethics Unit. As you all are aware, ICMR has been on a forefront for India's leadership in research ethics area for several decades, and there are numerous achievements, and it has been recognized for its work nationally as well as internationally. And it has a history of setting up the ethical guidelines, policy framework, instruments, tools that facilitate implementation of ethics requirements, building capacity across the country in biomedical and health research ethics, as well as not only for ethics committees, but also for researchers and students. We also have at the Department of Health Research the Ethics Committee Registration platform, which is the NATIC portal, and it is now mandatory for all ethics committees in India to be registered on the platform. And I also feel happy to tell you that we are also the WHO Collaborating Center for Strengthening Ethics in Biomedical and Health Research, and also for being the very first center in the whole of Southeast Asia region, and the only one so far, the only one center in ethics out of 14 global centers. And currently, I also feel honored to tell you that I am chairing the global network, the WHO Global Network for Collaborating Centers in Ethics. So India has been able to make a voice at the international front, and we really hope to keep up that. ICMR guidelines, as you all know, are very well respected in India, as well as many of our neighboring countries have also adopted parts of it as they are evolving their own ethical standards. So I'm really pleased and happy to welcome all of you to be part of today's discussion on a very relevant topic that we should be talking about, and that is people-centric research. And before we move on, I don't see the organizers here in the room, but I really want to thank St. John's National Academy for providing us this conference platform to reach out to all of you and for these important discussions. And I'll also like to take the opportunity to thank all of you, our invited guests who have come from across the country, and my colleagues from ICMR Network of Institutions for joining us today. And let me also thank my colleagues at ICMR Bioethics Unit, Dr. Raji, Dr. Elna, Dr. Dilip, and others who have been working day and night to make this event successful. So today is an important day as we look forward to building a healthier, safer, and fairer world. We strongly believe that research should be people-centric. And people, when meaningfully engaged, can also act as accelerator to bring the changes. People-centric approaches champion the active involvement of patients, communities, and other stakeholders throughout the entire research process. This shift is vital because it prioritizes the lived experiences, understands the unique needs, and brings up the invaluable perspective of the very individuals and communities our research aims to serve. So by doing so, we enhance the relevance of the research, improve the outcomes, and intend to ensure equitable distribution of benefits from the research endeavors. At the core of people-centric research lies true collaboration. It means people or patients, caregivers, community members participate in designing studies, setting research agendas, identifying outcomes that truly matter to them. This ensures our research addresses real-world needs. It involves co-designing studies with diverse stakeholders, from patients to clinicians and technology experts, making our research more robust, feasible, and acceptable. Furthermore, it emphasizes collecting data from real-life settings, providing insights that are far more applicable, leading to sustainable outcomes. Our Honorable Prime Minister, Shri Narendra Modi ji, has also been emphasizing the importance of people-centric approaches in governance and research in his various addresses. And similarly, our Union Health Minister, Shri J.P. Nadda ji, had launched a 5 DHR ICMR initiative, which includes an initiative on rare diseases, which propels people centricity in medical research. As part of the people-centric approaches, ICMR is also spearheading initiatives to develop affordable and effective therapies, and there have been certain calls for expression of interest in community engagement. WHO has called the 5 Ps, which is promoting, providing, protecting, powering, and performing for health, which supports the vision of leaving no one behind. The thought behind leaving no one behind is grounded in the UN normative standards, including the principles of equality and non-discrimination, and it is relevant for countries to take action to identify who is being marginalized, including those who are facing discrimination or exclusion in research. This meeting intends to rekindle a dialogue on people-centric approaches in medical research, as the impact of these approaches is profound. Today, we have this great opportunity to delve deeper into identifying what needs to be done at our end. And we will have 3 sessions, as you know, where we will try to understand the perspectives of the patient, or the community or research participant, and then we will like to listen to the researchers about what they can do, and finally we move to the session on ethics committees as to how ethics committees can guide this further. We hope that this today's session will help us to understand better what people truly want from medical research and their desire for active participation, clear communication, and the recognition of their invaluable contributions. We will explore how we can more meaningfully engage. And over the next 3 hours, let us engage in a constructive dialogue and to chart a clear way forward. I urge you all to very actively contribute and participate in the discourse and help us understand the desired next steps that we can take at our level in ICMR, so that future research in India can be more considerate and beneficial for the people of the country. So once again, thank you all very much for joining us today, and I really look forward to the deliberations. Thank you.
A very good afternoon to everyone. On behalf of ICMR Bioethics Unit, it is my pleasure again to extend a warm welcome to all of you to this meeting on addressing people-centric approaches in medical research. So we will begin with session 1, which is through the eyes of the people, understanding their needs. So we have people representatives here today, Mr. Gautam Dongre and Ms. Ritu Bhalla. And to start this session, I would like to invite our co-chairs for session 1, Dr. Jesani and Dr. Durga Gadgil, onto the dais. Please welcome them with a round of applause. May I please invite Dr. Jesani to give his opening remarks?
Welcome to everybody for attending this session. I think this is a very, very important topic for discussion. People-centric approaches. And people-centric means that we cannot do research the way we were doing, but we have to make some changes there. Research has been a top-down phenomenon all the time. We conceptualize, we do the methodology, we go to the people and ask them to come and participate in it. Now, how do you change this relationship in such a manner that there is a voice of people at every stage and every aspects of the research? I think that is a very critical and challenging issue. I'm happy that in medical research we are talking about it. I think in social sciences, with which I keep more relationship, I have found that these issues have been debated for very, very long time. I think in the early and mid 20th century, I remember coming across so many issues related to participatory research and participatory action research, or participatory clinical trials, where people themselves participate as a researcher along with the researchers from the outside. I think that is a very challenging area, and in medical research it hasn't been tried out to the extent as it should have been done. What has happened in medical research in our history, that people come into sin when there is a big controversy or scandal about human rights violation of some participants, or there is a very adverse reporting in the media, and then you find that people are talking and saying something is wrong. I think you must have seen it the way controversy started in 2010 to 2013 about the clinical trials. I don't think we require those kind of things to happen. And if you want to prevent it, I think this is the approach that we should be taking. That how do we consult people all the time at every stage, that what we should be researching, how we should be researching, and not only the expert reviewing the protocols, but can people also be involved in reviewing them? That can we have community-based ethics committees operating, and they're also looking at our protocols. That means we have to have more transparency in our research. That also means that our research has to become more democratic. This is a process of democratization. And mind well, it doesn't happen overnight. It's a process. And I'm very happy that today is the meeting where we are starting the process. And not only that, today is the session, the first session is actually about to find out what people want, right? And so I think we are going to have presentations here by the representatives who are coming from the patients and participant community, who are actually concerned about the research taking place, who are very much concerned about what kind of benefit they will get and how they will be protected in it. So let us, without having a long discussion on this, let us start with the presentations. I think there are two presenters. I request you to introduce them, yes, and we begin this.
Yes, we also have our co-chair for session 1, Dr. Durga Gadgil here, if she would like to give any remarks at the moment.
Won't say much except to say that Amar has really summed up everything, and I'm really keen to know what patients and people who have participated in research really expect out of it. And like we all know that there are researchers, institutions, ethics committees and regulators. However, the participants are the most important ones, because if they did not agree to be part of the research, you would have no research at all. So you would like to look forward to hearing from what the people want about this research and what they think about it. Thank you.
Thank you so much for those insightful opening remarks to both the co-chairs. May I please request our patient representative, Secretary NASCO from Nagpur, to please give his address.
Thank you so much. Good afternoon, all of you. I would like to extend my gratitude to Dr. Roli Mathur Madam to invite me, and also a team ICMR Bioethic Unit and organizer, for giving me the opportunity to share patients' thought on what they want from research. I come from sickle cell disease patient community. I am a caregiver. I have having experience because my son and daughter both are sickle cell warriors. I am a founder of sickle cell association called National Alliance of Sickle Cell Organization, NASCO. In India, there are more than 2 lakh sickle cell disease patients identified till today, in targeted screening program running since last 2 years under the mission. Sickle cell anemia elimination mission launched by Honorable Prime Minister Shri Narendra Modi ji in July 2023. The mission aims to eliminate sickle cell disease by 2047. Our country is the second largest country in the world with high prevalence of sickle cell disease. Most of the patients here live in tribal and remote areas. We have very limited option to survive. our patients wants more and more research to stop new birth with sickle cell disease and wants for quality of life to those who are living with deadly sickle cell disease. You all are aware that sickle cell disease is a genetic blood disorder. Research in this area should be more effective, safer, and personalized treatments for the condition that addresses symptoms, side effect, and overall well-being. Research that prioritizes patient needs, preferences, and experiences. Research that offers potential for better outcomes and improved prognosis. Research that provides accurate and reliable information to inform treatment choices. So ultimately, patients want research to improve their lives, elevate suffering, and provide hope for a better future. In other hand, when patients are involved in research or in clinical trials, they should benefit in several ways. Research studies should provide additional support, resources, or counseling for patients, which is more important. Researchers and ethics committees should ensure that patients are fully informed about potential benefits and risks, and that their participation is voluntary and respectful. That will show equal partnership in research with the patient's community. Some patients have had different experiences in research also, like not fully informed about its risk or potential benefits, adverse effect or side effects from experimental treatments. Some patients feel that researchers are not transparent about the research process, results, or potential conflicts of interest. They feel that they are being treated as test subjects rather than partner in research. Also, some time patients not receive adequate follow-up, care, or support after participating in research. These experiences can lead to mistrust, decreased participation, and wrong perceptions of research. Researchers should prioritize patient-centered approaches, transparency, and informed consent to mitigate these issues. At the end, research is the key to unlocking new discoveries and improving lives. It gives us hope for a better future where diseases are cured and lives are improved. Thank you for your attention.
May I please now request Ms. Ritu Bhalla from Can Kids, Delhi, to address us.
My name is Ritu Bhalla. I am two-time blood cancer survivor. I had cancer at the age of 4. I had non-Hodgkin's leukemia, lymphoma, and then at the age of 11, I got relapsed with the ALL. Both of the time, it was really difficult for me and my family to cope up because there was obviously cancer and lot of stigma attached to it, and there are a lot of financial crisis and obviously loss of a lot of hair loss, the overall look and feel of a child. I lost my childhood, I lost my friend, I lost a lot of things, my education as well. But yes, eventually I coped up and then cover it up with all my willpower and with all my support around the society, especially CanKids, my family members, and a few of my new friends which I've made while I got cancer and us in the survivor community. I'm also a survivor leader. Talking about it, I joined my cause very early in my childhood. I was 11, I got free from cancer and I joined CanKids. In 2006, I established Kids Can Connect, which is a KCK survivor teenager and young adult group. I'm the founding member with my co-leaders, 5-6 co-leaders. And this is a very special wing of CanKids where we ensure that a survivor, when a cancer patient get cured, it got a proper reintegration back into the society without any guilt, and we provide a peer support with every possible way to them under CanKids. I also, serve as a patient advocate at different platforms on national and international level, with a very strong focus on fighting stigma and actually talking about the rights of patients and survivors during and after cancer treatment, because I feel the things which I have faced and struggled during my time should not be, faced by the family and the children especially who are going through the cancer treatment right now. And there is a lot of, literacy, there is a lot of, support generated. I think right now and during this time, a lot of, people, institutions, and, bodies are coming together to support this cause, and I think we should leverage that. And therefore, I talk a lot and give them a real-time, examples to rectify them. I also led a lot of patient-led research studies, including a published paper on gender bias in the treatment of girl childhood cancer patients. This is very close to my heart, this project, because when I started working as a professional, I got to see a very drop rate of girl child coming for a treatment vis-a-vis boys. This is especially in North India, and that's what triggered us to initiate this project. And this is very close to my heart because we have certainly over the period of time, this was started in 2013, and over the period of time we have transformed and we have changed, and we have definitely derived a compassion, a confidence level in the girl child across the major cities of the northern India, and we are still trying to push many girls in different part of India as well. This has been now a national study and got published. I also played a very key role in the PACER project with Apar, another body who are working on the research area, and with CanKids, we together ensure that patient advocates should be there, in their participation should be there in the research area wherever they can participate in whichever capacity they can contribute. We and also we build capacity across 25 patient advocacy group to strengthen the evidence-based advocacy on national and international level. My transformation and my integration and a quick life status. Right now, I am a working professional. I work with corporate, but I do ensure that I give back to my cause on the weekends or on a voluntary basis, and that's how I ensure I get attached to my cause and bring change in the society, which I really wanted to see. I'm also married to a childhood cancer survivor. His name is Kumar. We both were core leaders for Kids Can Connect at CanKids, and eventually we fall in love, and then we got married, and now we have a beautiful daughter. And we together, ensure that we give back to the cause by any which way we can do it from our side. The Girl Childhood Cancer Survivors Patient Project We started in 2013 in PJMS Rohtak Hospital with 9 girl patients and survivors. And this was a long back. I mean, we started with one, and we reached out to 120 plus girl across 6 different cities by the time we reached to 2018 and 19. And then we realized, there is a time to see how we have impacted their life. And in 2019 we started again, checking on them. We called them back, we get back to their life. We spoke to them, we had a different interview. We have actually prepared a different level of questionnaire to see whether they feel empowered being part of this project or not. The idea of establishing this research study was one, to see is there a real-time gender inequality happening across India. The second was there was myth around preference of boys for a cancer treatment vis-a-vis girl, and there was overall cancer stigma in the society, and that was influencing the patient and the family members, and therefore they were abandoning the treatment. There was no peer support for them, and there was no motivation factor for those girls who were suffering from cancer or were being a survivor. So just wanted to talk 1 minute about this study, because I myself was on a ground basis involved and have established this study and have faced multiple level of challenges, because I was really a layman. I did not had a previous experience of doing any study, any research, but I really had to sit down and go to and visit different hospitals, talking to different doctors to get the data, to actually ask their help to support this study, to actually give us the insight of their own, from their own clinics, how they are looking at girl versus boy. Is there any gender equality? What kind of initiatives we should take? So all these challenges from starting from doctor to over the period of time, this study got published in March this year, and after 5 to 6 years of struggle, because it was led by me, a survivor. I am not a scientist, I am not a doctor, and I had to fought a lot with different people at different organizations, at different institute, at different publishing bodies, because I am not a doctor or scientist. So how should I prove my qualification to publish this study? So that was a challenge for me as a patient advocate. How should I ensure my participation and the work I have done? So that was very very stressful in a way, that I have other works to do, but I have to ensure that this should not let go somewhere. So after finally we got to had a word with Indian Journal of Public Health Research. They were very generous, and they have finally published our paper, and it is there in their copy. I can share it with the team later after this presentation. I am very happy and very proud that we have made some impact in the girl's life, and now they are working. They feel very confident and very empowered in that way. I'll just quickly sum up. Wanted to share 2 quick stories while we are talking about the patient centricity. I would like to highlight how our involvement can be there. One, as a patient advocate, while we have suffered, we have seen everything, how we can contribute to research as a giving the real-time examples. Second, as a patient, how my involvement should be there. So these are the real-time stories which I am sharing. So first is challenges faced as a patient advocate. This is real-time mine and my husband's experience. So when we were working on this gender bias study, I had to constantly push to keep the focus on the girl child. It wasn't easy to convince the doctor researchers that the story mattered just as much as the others' research papers or the stories. Around the same time, my husband Chandan was leading the project Passport to Life, and he faced a similar resistance. He had to fight to make sure the study went beyond late effect and addressed survivor long-term needs. Both of us stood ground, and these struggles were not just about research, they were about making spaces for survivors' voices where they had long been missing. So we had to, put our foot down to say, you have to keep focus on what we are aiming to achieve, with not just that, it is just for a sake of paper to publish. That is what our focus was. The second instance where I as a patient, because I have a long-term side effect, chronic hepatitis B out of my cancer, and one day I went to my follow-up. I was waiting for my turn in the liver clinic, and a woman, possibly I think she was a coordinator, she called my name and asked me to step into the room, and then explained, very little explained that, okay, one study is going on, can you give your blood sample? I said, why? This is a time when I was already participated in 2 research, and I know that there has to be a consent form because I have run my study, gender bias, there has to be information sheet, there has to be completely thoroughly explained before you take their the patient's participation. So I denied. I said, give me the information sheet, where is your consent form? I asked for it, and she got baffled about it. She said, senior doctor execute kar rahe hain. The senior doctor of this department is executing this study. We are checking some vaccination which is working for the chronic hepatitis B patient. Can you please participate? I said, no, until you give me the information sheet, the papers required, the knowledge which I require, I will not participate, I will not give my sample. So, a portal should be patient friendly, or the team who is working on the research, who is taking a communication, who is doing communication with the patient, has to be clear that these are the norms, these are the rules and regulations that you need to follow. Patient should not be fooled off. Patient has to be treated as a partner in the research study, not should be as a subject. That is our point. So if you talk about these 2 aspects, I think that is very important to take into consideration when we are talking about the patient centricity, right? And I think these are the things when we are talking about the need to be equal in the partnership research. So patient voice should be heard, number 1. Vis-a-vis, I have listed down what we want as a patient advocate, right? So patient voice should be heard, and patient engagement should be there during the priority settings. When you are sitting down together as a team and planning what research has to be done, 2 minutes. Thank you. Sorry, but this is, I think, something very important I am pointing out over here, so therefore I am taking time. Just 2 minutes, I will wrap it up. So when team is sitting, planning the research, there has to be patient engagement or a patient advocate engagement in the priority setting so that they can give their input. Input in the protocol has to be there. When protocol is drafted, it has to be circulated with the patient advocate or the patient as well, because that was being a part of the team initially. Participation in the ethics committee will give them a lot of exposure, because they haven't been into such kind of environment, and it will enhance their knowledge and eventually build their capacities. And the final point is friendly participation initiative. So for example, procedure should be painless. Information can be done in a simple language. Or a blood sample, if you need to take during the research study, it has to be, if patient can't visit hospital, it has to be home visit. So some practical approaches has to be there, should be taken care of. And this is what we want. So patient survivors should be asked to participate in the research and should be trained. Easy, simple way to understand research should be there, because we are not we are not technical equipped with the kind of terminologies which is used in the research area. Real-time engagement on different steps during the research should be ensured. Training and capacity building of patient advocates should be, planned while you are planning the research, or there has to be a timeline. So this should be considered. The last thing is the website portal such as CTRI should be patient friendly. It is now, if I see and go and do the research for different, as per different guidelines or as per different, disease, it is more for scientists, research professionals, doctors, etc. with heavy terminology. It is not for me, because I am not a research person, I am a management professional, right? So how CTRI or ICMR can, think about these things when we are talking about patient centricity, right? And there should be, redefined definition of this portal should be simplified for a patient advocate. The last slide, the second last slide quickly, what meaningful engagement look like. Membership of ethics committee should be, there for the patient advocates and patients. Voluntary participation in any phase of study should be allowed. Participation in priority setting, which I have already talked about. Community engagement initiatives, sharing the real-time benefit. Like you have called me, you have invited me to share the real-time experiences. Such platform should be provided to other patient and patient advocates to raise up their voice and share their real-time experiences. There should be reward and recognition. A small reward and recognition while their participation is there in the research will make a lot of difference, because it will ultimately, motivate them to participate in another research or actually bring them more advocate to the research platform. Provide a platform to voice out their personal experiences and feedback. Research training session should be there, and hands-on learning experience should be there. And last 5 points, sorry, please pardon the numbers, but just 5 points to be echoed very highly. Nothing about me without me. So consent should be there. If you are talking about any research, or you should, explain me as a patient and then, go ahead. You should not, fool myself, fool the patient if you are part of a research team. Patients are not just a subject, which I highlighted. They should be a partners. Practical patient centricity approach should be there. National and international stakeholders like ICMR, WHO, collaboration to build capacity and encourage more patient advocates to come forward and participate should be taken care of, and patients should be able to access research trials and what will benefit them. So these are my 5 important points which I would like to sum up through this presentation, and thank you so much for having me. Any questions? I would like to answer them.
Thank you very much. Can you just take a seat, please?
Sure.
I think we have very good presentations. I mean, you have taken a lot of time, and that might reduce the participation from the audience. But the good part is that we have 2 cases. We have sickle cell disease, and we have carcinoma. Both of them have certain commonalities. The one common thing is, as you have both of them may explain, is stigma. There's a huge stigma against both the diseases. The sickle cell is worst as compared to cancer. Okay? Because cancer now in the middle class, many people are suffering from, and then we can identify with them much better and empathize also. But what Mr. Dongre talked about, because this is the disease of the people who themselves are neglected, and they themselves are stigmatized, as a community. The tribals and Dalits who suffer from it. Not only that, I think sickle cell disease is often called Adivasi disease, right? And once you say that it's Adivasiyon ka disease, it immediately brings a stigma there. I think that's how it's a very, very important that this disease is a given priority. It was not given priority for very, very long time. And I know that how your organizations have struggled over the years. For last 30, 40 years that I have been looking at what work you have been doing. So it's very important that diseases which are neglected and they are more prevalent among the vulnerable people, they are brought on the priority. I think if that is not done, we will not be able to get the participation. And Ritu, you have really provided us a lot of things to think about here. But one point that I would like to emphasize, you are talking about patients, advocates. Classically, in the clinical research, doctor is supposed to be patient advocate. And what you have brought out from your experience, and I think what Dongre has also said, is that unfortunately we people, I am also a doctor, we people are not really patient advocate. When we become scientists, we become advocate for the science. When we are doing clinical research, we become advocate for the clinical work. And we forget the most important person, the patient and the participant. So we need, there was an effort made over the years that ethics committee should also be doing monitoring, and so ethics committee should be the best advocate. But ethics committee has a lot of limitations and they are not able to play that role. So the new category that you are talking about, that these advocates should be there in all clinical research and who should be helping the participants who are not able to understand and protect their rights. I think that is a very, very important point you have made. You would like to say something before we ask?
Yeah, just a few words. Thank you so much for this really eye-opening presentations. And like Amar said, sickle cell disease is something that's really affecting a number of people, and it's not really much into the limelight as such. And the take-home message which you gave was very important, that there should be transparency in the research that is being undertaken, and a properly informed consent should be taken, or the patient should be told in the manner they understand. Because if they are a tribal population, they are not able to understand much. There should be some advocate who is able to translate what this research means for them, giving them some post-trial access, telling them how to take care. Maybe also, if it's a genetic disease, then some preventive measures, because if it's a tribal population, there could be a lot of intermarriages, consanguineous marriages. So how it can be prevented, if that can also be done. So that's a good take-home message which we got from your presentation. That's excellent. From Ritu, this thing, I completely agree, because when we started research way back in early 90s, it was inform the patient where to sign. And that's not how it should be done now. It has to be an written informed consent. So it should be in a language which is easy to understand. The investigator should be ready to discuss all the pros and cons with you. So it's unfortunate that even as recently as now, it was the same situation of inform the patient where to sign. That's not how research should be done, and participants are right in expecting there should be transparency and a full disclosure of what it means, and that you're going to do research, and what are the pros and cons, risk and benefit, which even Gautam brought about, that tell them the risks and benefit of these treatments. It's not like it's going to cure everything or treat everything. Be honest about the outcomes. And your publication, which has happened, congratulations, that's excellent. And I think you brought out a very important point about the importance of a girl child or a woman in research. They are also very important, and special attention should be given to them, because I think women even today are considered or should be considered vulnerable in various ways, though we don't like to say that. I think patient-centric approach was also another important take-home message. And nowadays, with decentralized clinical trials, that's what we try to do. Take the study to the patient rather than bring the patient to the study site. So I think that was another important take-home message which I got. And thank you so much. And rewards and recognition, if it's just some small gift or something, it may be accepted, but ethics committees may not accept other types of rewards and recognition for being participants. Yeah, but a small token, yes, that's definitely the case, because that helps to build the participants' confidence and help that other research participants can take part in it as well. And what I personally feel from all this is that we as researchers or ethics committees, or we should be training the general public on research, because even today there's a lot of this misconception that research means you're treating these patients as guinea pigs. And we're never going to treat them as guinea pigs, because guinea pigs, the disease is introduced in them. In participants, they are already having the disease. So there are lots of differences between, understanding what is research. So I think training general public in different forum could be an important way to take this forward. That's all I want to say. Thank you.
Can I add 2 points?
Yeah, please, go ahead.
So, just to reiterate, under the rewards and recognition, and I wanted to convey that some couple of opportunities which may increase the confidence level of a new patient advocate or a patient who is participating in the research. Just to give an example, when I started this girl-child study in 2013, after 6 months, Poonam ma'am introduced me, why don't you go and present your work to PSYOP International and CCI International in Hong Kong. And it was really, because I am coming from a humble background, I never went to Videsh and I never had an experience of doing such presentation which I do today. I was never been that girl outspoken, talking about the things. And I questioned myself. I never had a experience of writing an abstract. I literally wrote an essay, So I have, built my experience over the time, but that opportunity gave me so much exposure and that confidence level. And after that, I never, stopped myself participating in the research anytime. Any international research, if a little contribution come to me for, to participate or to just, give my inputs, I do participate. Because this kind of opportunity I'm talking about, which will motivate it further. And the second point which I am talking about is about the last point you have talking about the capacity building and training. So, yeah. So under that also, I think when we are focusing on a capacity building of a patient advocate or patient to come in the core group of the research or the ethics committee work or any preparation of the documentation, there has to be teach that you have to be very patient with the process, because this is a very very intense, very thoughtful, very mindful things which we are going to do, but it requires a level of a patience which is need to be teach, because sometimes personality do vary. So that is what I learned, and I think that should be considered also.
Thank you. I think you can imagine with your education, you were so diffident in front of the medicine and the science. What must be happening to people who are semi-literate, who are completely marginalized, who are stigmatized,
Exactly.
So given that kind of situation,
Exactly.
So I think I had seen it in medical practice also. I see that patients are not able to speak out.
Also, sir.
Now,
yes.
Point is, if they are not, how do we actually get them in to participate in a meaningful way? So I hope that middle class people and educated people like you who are there will go beyond, your call, not just for you, but also work for sickle cell, also work for the other people, who are actually not having voice. To give them a voice is the one that both of you can do. And unless that voice is raised and raised in a very strong way,
Right.
I don't think you will be able to change the system.
Right.
So I hope you are able to do it. Anyway, I think we are overshot the time, and we should be concluding here. Thank you very much for your contribution, and thank you everybody for patiently listening to this.
Thank you everyone. Thank you everyone on the dais. So now that we have captured the patient's perspective, the real challenge begins, translating these insights into actionable strategies, and that is why we want to know what the researchers must do. We'll have a panel discussion. We'll have 2 chairs co-chairing it, and we'll have 4 panelists. So I kindly request the chairpersons and the panelists to please come up on the dais. I extend my warm welcome to Dr. Shalini Bharat, Dr. Aparna Mittal, Dr. Manisha Ghate, Dr. Naro Chandola, Dr. Sandip Mukhopadhyay, and Dr. Ananya Samajdar.
You all as researcher. It is actually very, very humbling to listen to, the voices of people here. In the previous session, it was actually the patients and the patient caregivers. I think this is really what we understand from, listening to the voices. And as researchers, especially I have been researching, in the HIV epidemic field. I know exactly, how we have been part of the movement of, bringing about this entire change in people-centric research. So very quickly, let me just give a very small, some remarks on the theme of this session. Basically, in the early 1970s, when Robert Chambers emphasized the need for participatory research, as one of the most important ways of, gathering information and advancing science, it was to really give the emphasis on the fact that people have first-hand information, they have lived experiences, and that they also have, insights into their problems and issues. And we just heard from both Ritu, Bhalla and Mr. Dongre what it means to be in that position, what it means to be living that, having that experience. Earlier, of course, it was not just Robert Chambers, but there has been a big shift, as researchers would know, from a very positivistic kind of science to critical social science, feminism, constructivism, and of course pragmatism, which talks about bringing people into research and not treating them only as providers of knowledge, but also as co-creators of knowledge. That they are partners in knowledge production, which is when you take this kind of view, then you are actively listening to their stories and actively listening to what they want to say. Also, that it is very important that they are not only brought in at the time of doing research or data collection, but also as part of designing research, planning it, implementing it. And I'm very sure all of you will agree that it has a different quality to that kind of science. What Mr. Dongre talked about, bringing transparency into research process, very important. Therefore, it has to begin from the stage of designing the project or the research. And what Ms. Bhalla talked about, sharing knowledge and taking patients and people who are especially who are articulate, the entire process, I think is very important. But despite understanding what is patient-centric research or the value of patient-centric research, we find that there is still a lot of vagueness about what really patient-centric research is all about. How do we engage patients? How do we bring about a meaningful involvement of people? What is the role communities can play, etc. So in a way, we need to engage with these issues, and we have 4 panelists who will talk about what it means from their end. But there are 3 or 4 points I would like to flag. One is that when we talk about patient-centric research, we have to understand how does it differ from a non-patient-centric research, especially for medical researchers and public health researchers. The key point to remember is in terms of the locus of control and the ownership of research. So the locus of control is not just with researchers, it has to be with people. We are sharing that control process. We are also sharing the ownership of data production of the entire research process. Second thing is that people-centric research is not a methodology per se, it's an orientation, it's an approach to how we treat people and communities in the part of research process, production of knowledge. A third very important point is that patient-centric research is by nature participatory, but not all participatory research will be patient-centric research or people-centric research. We have to make it people-centric, which means that you're not just focusing on the disease or the individual problem, but you're exploring the context, the circumstances, the entire situation in which something unfolds. As Mr. Dongre said, if he just speaks about his problem of sickle cell anemia and does not talk about the tribal status, the particular Maharashtra, the status, we don't exactly understand the whole problem, especially of stigma. And fourthly, I will say that participatory research is qualitative in nature, but let us be very clear that quantitative research, positivistic science also can align itself with people-centric research. And I would argue that it should be done, because in many interventions and so on, we use participatory research process. So with that, I will ask if Dr. Mittal wants to add something now, or we listen to the 4 panelists and then, but maybe you.
So first off, I'm not a doctor. I'm just Aparna Mittal. I don't have a medical background. And I represent the voice of the patient as well. I think 2 things that I do want to touch on as well is we still consider the clinician and the researcher as the expert and the patient as a person or a patient. And I think we need to acknowledge that they are experts by lived experience. There are many non-clinical aspects in healthcare which come into play even during a research study, and we continue to neglect this unless we look at the role of the patient and the caregiver in managing their condition. And time and again, in our experience of listening to thousands of patients and documenting their narratives, we realize that expertise plays a key role in improving outcomes. And increasingly, it needs to be more studied. In fact, the most recent study said that as well. The other thing I think as researchers we need to be very conscious of as we progress further is who owns the data. And we still find enough cases where if a sample has been taken earlier, can you use it for a study or not? What is the ethics behind that? What is the disclosure that will come through analyzing that for genetics or genotyping, etc. So I think it's important as researchers to think about these aspects as well. And I won't take too much more of the time. I think we should start with the panelists as well. I think we basically want you to talk about the challenges that you find in involving patients early on or people early on in the research, and if you can share one example very quickly.
So I'll talk about the challenges, and today, after listening to excellent presentations by the patient perspective, I would like to share one of the biggest challenges: building trust of the community and the participants in the research. And I can give that example in our experience. What we have done is we have involved participants right from the beginning, community right from the beginning. So their involvement is before, during, and even after the research is done. For before involvement, community visits, talking about what exactly research is, what exactly the researchers are going to do it is very important. Even to ask how we should inform the participants about it and get idea into that. And at our institute, we have a vibrant community advisory board where representatives from all the communities are there, and they advise us as to how we should take our research to the community. That's one of the things that we have done as an example. Second is requesting participants to develop the education material is also very important. That initiative we have taken, and it was extremely useful for us, because clinicians tend to develop the material with their own perspective, and it's very important that when we do research in the community, to take community into confidence and just take their opinion as to how we should give the education material to them. Third important thing after research is dissemination of the results to the community, because the research in which they have participated, it's very important, and even try to give them post-research or post-trial access. And one of the examples is I will take example of 2 things. One is clinical trial that was conducted at our institute, and it was for HIV infected individuals. And after the trial was over, we saw to it that they get access to free antiretroviral treatment to government program. So they could continue their treatment, and it was not stopped at all. So giving access to the treatment. Even for one of the ocular studies in HIV infected individuals, the spectacles were given to them, specs were given to them after the research was over. So whatever standard of care and medical care is essential, post-study was provided to them. So involvement of community before, during, and after the research is extremely important. Second challenge is about retention of the participant. So as Ritu has very correctly said, that for retention into clinical trials and longitudinal studies, which are very important, which have very important outcomes, it is important to take into consideration convenience of the participant. And I can give one example is, we kept our clinics open even on Saturdays, Sundays, and at time which was convenient to the participant. And also whenever the participants requested for anything like blood collection, we did provide that during the study, and it was very useful. And I completely agree that unless the research is patient-centric or participant-centric, it will not be a success. And I agree that even post-research, the findings should be communicated to the community so that they get an idea and even they get acquainted with the research things that are conducted by the research institutions. Thank you.
Naro, Chandola, what has been your experience as a clinical trialist in engaging community advisory boards? And if you can talk a little bit also of the challenges and the benefits when you were partnering early.
Sure. It's a very brief context that I work with the urban poor population, which is has a different set of challenge, as in they're more individualistic as compared to rural communities that are more communal, because maybe they have more shared background. So with that background, we have been working on clinical trials for a long time, and I just want to say that we don't work with a specific disease population or a particular disease population group, but with communities who are like sort of healthy participants. So that's with that backdrop and with a commitment that we would want to do people-centric research, we have a very engaged community advisory board. So the people of the community advisory board are from different walks of life, and we were also very conscious in ensuring that they had some amount of influence, like school teachers or the RWAs, and we have a private practitioner there, and also that they are known in the community. And these are the people who have been chosen so that they can guide us and give feedback on the way that we do our research, and specifically because we haven't evolved so much that they give feedback on the scientific aspects of it, but on the operational aspects. And it has been a wonderful journey so far. And I can just cite a few examples. Like I mentioned, we do a lot of vaccine trials, and like you were just mentioning, we also at the outset share with the CAB members what the study is about, so that they are oriented, and it really helped us because every now and then there are myths and this rumors in the community, specifically when it's vaccine trials, saying the government is giving this vaccine so that you become infertile, and this is a sort of a propaganda against a certain minority group. So things like that, the myths, because they are already aware of what we are doing, they are the ones, not we, because we are sort of on the opposite camp, and so they are the ones to sort of speak for us and explain. So that's been one thing that's been really, really helpful. We try our best in that, so that's for the vaccine trials, but for such surveillance studies or observational studies, we do try our best to listen to what they have to say. So a very recent example that I'm very proud of was we are doing a study where we have a lot of blood collection from each individual. So the feedback we got is the number of times you're going to take the blood is so much. So we actually sat down and we rationalized, and we now have a lesser number of sample draws from each participant, and we just made like a certain group at a certain time, so the research question is not undermined. There's still rigor in science, but we still also are able to do something that the participants expected us to do. And like you mentioned, we do the same thing. The patient's convenience is comes before what we do. So when we do studies on adolescents, school-going children, the team changes their time because you cannot expect to meet them during the working hours. So they have shift duties. So that's been just amazing to have this support. And during the COVID, it was really, they were really, really did an amazing job, because for some reason in our community, okay, so, think that people with lab coats are the ones who are spreading that, so they helped us design awareness, posters, and they are the ones who guided us, and so that really helped. The only challenge I can say is keeping the CAB members very apolitical, and sometimes they tend to get entitled, and then they will say like, can you hire this one or somebody? So as we follow good participatory practices, so we do try to take people from the community, but we have a very strict procedure. So that's the one challenge that we need to really tell them time and again that, you need to follow that. Thank you very much.
So, Dr. Sandip Mukhopadhyay, what in your view are the key elements, because you work in the, at National Institute for Research and you're in multiple ethics committees. What in your view are the key elements of a patient or people-centric medical or public health research design? And again, can you share one such design?
So first of all, I would like to thank the organizers and ICMR Bioethics Unit to give me this opportunity to sit in front of you and in front of this learned audience. This particular topic, actually I am getting fascinated. This is a more learning for me in front of you, and I was just trying to understand Jesani sir's what he mentioned at the beginning. Being a medical doctor, I am also a medical doctor. When we did our MDs in our days, probably in India there was 1,500 MD seats all over the country. And from day one, we had been taught since our MBBS. I am basically from a very humble background. The place from where I came out for medical science, it was hardly 1 kilometer away from a tea garden and 2-3 kilometers away from a forest. So from there, तो हमें वही सिखाया गया था कि you have to provide service to the community. There was no scope of research at that time. Even in our MD days, when I joined MD, I was very much interested. I had a keen interest towards research, but still the primary focus remained service. But now the scenario is changing, and to the best of my knowledge, India has almost 70,000 MD, MS, DNB seats compared to our 1,500 seats. So now we can talk about research, and we can understand that if only a part of these people, 5% or 10% of these people are engaged in proper meaningful research, the country will not have any dearth of data. So we can now think of people-centric research and other things which were probably not possible in our earlier days. So with this background, I would like to say that to me, for a public health research, people-centric approach is care. So what is care? C for collaborative with the communities from the beginning. A is addressing the real world need, what is actually needed by the community, and provide adequate CDE, that is the comfort, dignity, and overall the experience of the participants. Then coming to R is respect to the values and the diversity. So the design should be culturally apt to address the local needs, and it should not harm the local sentiments, or there should not be any mistrust about it also. And E is the last word that is very important: engage ethically, empathetically, and transparently. So it means that you have to share the goals, the risks, and the results also meaningfully to the population. So again, another C is coming. So C and E, communication and empathy, these two terms will come in any public health research. And to me, just a small modification, if it is a medical research where the whole community is not directly involved in that way, like a hospital-based study or something we are doing at individual level, like the clinical trials, etc. The meaning of this research is heart. So we know that ethics should come from heart. So the mnemonic is heart. So H is human-centric. E is empower and engage ethically. Again, the same concept that dignity and rights should not be ignored. Then A is accessible to all across the society, across the education level, financial level, etc. Then it must be accessible, and result is focused to the real world. And T is the communication. It must be a two-way communication. It should not be a monologue. It should be a dialogue. So the people should be given the chances to ask questions, and I have to answer the questions.
Ananya, Samajdar, on the key differences that you see, because you work more in the grassroots research. So compared to clinical trials or medical research or public health research, what are the differences you see when you work at in grassroots research? And again, if you can share with example.
Sure. So whatever I will be sharing today will be from the perspective of grassroots research. And first of all, it's an honor here to be speaking here in the presence of the esteemed chair and such accomplished speakers. I think, it's been wonderful to listen to them. So when it comes to engaging, of course, here we talk about people-centric research and the important element being community engagement. And my organization, GRAM, has a very strong belief in community-centric research, and our research and evaluation, we do a lot of program evaluation. So our evaluation and research involves engaging communities at different stages. So whatever it is about community engagement is that there is a very strong belief and acceptance that it should go beyond tokenism, because there's often, there's this thing that we have to involve community, we have to engage community, but it sometimes just becomes for its own sake. So going beyond tokenism is important, and definitely, there is the intent is to involve community, the members of the community beyond being sources of data. So of course, they will be, we interview them, we do surveys or we do FGDs, in-depth interviews. So the whole intent and the whole idea is to make them, involve them in all the different stages of research. So it has already been spoken about today that right from the design stage. And one very important aspect is in defining the research questions. Mm-hmm. What is it that they would like to learn? What is it that they want to know? And my organization also believes in picking up research questions from the ground, for research that is truly informed by community needs. Data collection also. So we think that they are sources of data, but they can also be data collectors. So peer-to-peer data collection sometimes, it increases the trust. And of course, in any way engaging members of the community, it helps to increase the buy-in and the support which we have for the research. And of course, there are other ways also we can involve them. Data interpretation. Of course, it may not always be practical to have members of the community analyze data, but data interpretation. So for example, we show them the figures that, there has been a reduction in this. So these are the patterns coming from the quantitative analysis. So what do you make of it? Why has this happened? So that interpretation can actually happen. Then we often in our kind of social science research is very policy oriented, action oriented. We would like to use the findings to do something, to suggest some changes or to bring about positive changes. So sharing the findings with them and getting their recommendations and getting members of the community to also disseminate. So they can disseminate the findings to other members of the community. See, when we do it, it's through that same old PPT or that same old report. You ask them, you may get folk songs, you may get a lovely, sometimes even you get young people, they may be using Instagram. I've even heard of rap to disseminate findings of research. So there are so many interesting ways and different stages. Examples being, one is that my organization did a study in Jammu and Kashmir. So with the nomadic Bakarwal community. So first of all, they were there in the pastures during their migration phase. So we did the normal, usual survey and all there. Then they came down to Rajouri, which is their base settlement. And then we shared the findings of our study with them. And then we took their suggestions, in terms of what should the government do? What kind of measures can be taken to improve their healthcare access? And they had made a number of suggestions there, which I'll not get into right now. The other way was another example where my organization involved them in the monitoring of health centers. So members of the community, of course, are the users of their health centers, the primary health centers, facilities, etc. So we actually asked them to score their health centers, and that was used for a community ranking. So community monitoring is another interesting way. Then participatory rural appraisal, to kind of identify patterns, map problems, all those things can also be done. So many interesting ways. And I think that ultimately going forward, there are some things which need to be done. One is, of course, has already been shared by Ms. Ritu ji about capacity building, acknowledging the contribution, having proper budgetary allocation, sensitizing donors about the importance of engaging community, and then convincing community why it is important for them to participate, and that proper the skills we as researchers need. That's my last point really. The skills that we as researchers need is that proper facilitation, that proper communication. It can, there are limitations of time. So the proper communication skills are needed, and to amplify the quiet voices. Because again, that's essentially what it's about. Like, some people are really active and outspoken, but not everybody else. Yeah, thank you so much.
So thank you to all the panelists, and I think they've kept to time. Just as we heard the patients speak about their experiences, and those who are caregivers speak about their experiences, I think here the researchers also have spoken really from their lived experience as researchers, I would say, because the finer nuances that they have brought out really are grounded in the research that they have done, and they have listened to community voices and the challenges that they have faced. So I think they have shared a wealth of information, and I'm sure researchers present here will take note of those. I'm not going to comment on what they have said. Rather, I would like, if there are some discussions from the questions from the audience, but if you would like to say anything at this point in time, I think we'll open it to for some quick Q&A with the audience. So if there are questions, there is a. Can you please pass the mic, last but second row?
Thanks for this excellent presentation. It's not a question. I just I want to add where Ananya stops. See, this is like from a people-centric approach. Some of us, I'm from Swachara, Amir Khan. I closely worked with the Tamil Nadu public health system to strengthen the community process in health in India. So, and from a people-centric approach, I think system also moved to a people-led research, a community-led research rather than the community-centered research, which is essential, which is kind of, it still has to grow, but we have moved to the other side of the research of people-led research. And that adds the kind of a important aspect of who owns the data. If the research institute does it, and the hegemony and the kind of a power of data lies with either the system or the civil society organization or the research institute like ICMR, where nothing wrong, but it just lies there. But in some of our experiment, we try to give data back to the community. And the community monitoring example, what Ananya said, and we have coordinated with the Tamil Nadu government and all. The entire data is with the Panchayat president, because they are the one who is owning, who has to implement the thing. So we just give back the data to Panchayat president, Gram Panchayat. The third point is like, yeah, and I think this needs to move to like research in people's hand from a kind of research-centric approach. So bring public into public health, and bring kind of people into people's health movement, all those things. I think the research has to go back to the people's hand. So that's where we have to move it.
I think the point that you are making about community-led research or people-led research is also very valid, because There are many examples where communities have designed their own research, and so it really sort of brings down the researchers to the ground level, that this is not something that only experts, so-called experts, can do. Expertise can be of different kinds, and some of this expertise lies with the community, and there are many examples. So very good for you to point out this. I think, as I said, the issue about the locus of control and ownership is a very important one, which people-centric research deals with. So thank you for bringing attention to that. Yeah, please.
Yeah, I just wanted to say about the database that you talked about. Actually, if and what he said, and which is correct, that you pointed out at the beginning, involvement at the research design stage is important. Participating during research is important, or all of you highlighted coming back to the community. But I think what often gets missed is what happened with the research. And did you actually, is there an audit at the end of it which says you did research for a purpose, what difference did it make on the ground? And did it actually lead to some change or not? And I think that piece often gets missed out. So you have researchers on the panel, and often researchers get very busy doing research and publishing. But I have, as a patient advocate, always felt that at the end, did you actually create on-ground difference? And who checked that? Who checked, did it actually make a difference to something?
Yeah.
Right.
So can I ask at least one of you to just answer this? Maybe Ananya could, if, the kind of grounds level research, what difference did it make to, or Manisha can, yeah.
This is a very valid and important point, and I completely agree with you. And this is basically dissemination of data or research findings, taking it to the community, which is extremely important. And I can take example of HIV, because I'm working in the institute of where we are doing research on HIV and AIDS. And there what we have done is one or two clinical trials that changed the global guidelines, like HPT 052. In our, we have number of patients that are visiting. The participants do visit for standard of care, coming to us for ART. And during that time, we had many discussions with those participants, and we made a point to inform them in a very simple language that how valuable their contribution was and how it has changed even the treatment guidelines. And now HIV treatment is freely available to all those who are tested positive. So this was communicated to the participants, and this is extremely, we don't go in the community, but those who are visiting us, we do inform them what difference it has made. But this is very important point, that it must be informed. Dissemination of findings, taking them back to the community is very important.
So do you put into your budget any money for putting it into the press or putting it out in the public space? Let's say even in local press. Let's say you do something in a particular community. What did you do to disseminate your results at the end, and what difference did it make? I don't see it in anybody's budgets. So we very, very seldom see. Even just the other day I was telling a bunch of doctors, why aren't you even posting on LinkedIn what you're researching? Why aren't you posting on social media so the common public gets to know what you're doing? Your research is only known within your own community of researchers, or within the community of doctors, or ICMR may know. But what about the common person? So if you're doing community research, did you at the end provide a budget to say, I will put in the press, we did this research, this happened, and this is the benefit to your community? It could be in the local this thing. If it's a countrywide research study, then did you put it into the press, and did you create a budget to do that, so that as the common person I got to know, oh, there was a research that happened and this is what became of it. This now makes me move forward within my country.
Can you just share, because HIV, I think budgets are all...
We have budgeted for all the reports and even community
so that
thing.
is the simple
and
answer.
For HIV, I can talk about this, and we do it starts with the CAP, to the participant, to the press. I'm not sure whether it was taken, we didn't publish in the country thing, but for locals who participated that, we did have the budget for that, and even for taking it to the community. But your point is valid, and it should be taken if it is really significant, that is making difference to the guidelines, national guidelines, it should be taken to at the country level. But there are some research proposals or clinical trials that are restricted to the local needs. And I think for that, those who are really getting benefited or those who it is important for them, they must know about it, that what happened and how their participants has resulted into such kind of changes to the humanity. And we do acknowledge that, and we really, it's a sort of thanksgiving for them. Thanks.
If I may just add, since I work more on vaccine trials, so may not answer your question as a patient, but like you were mentioning, if it's a very important study, and if that's impacting policy, then yes, it is part of the budget, and yes, even the government does do it. So we did the RotaVac vaccine evaluation, and now RotaVac is part of the immunization program. So that's the dissemination, or it's right out there, and you can see the evidence. But it's not like that for all the research that you do. So like some of them, if they're more, like not exploratory ones, I think it just doesn't get that disseminated. And even if you try to put a budget, I'm not sure funding agencies are really happy to give us that budget. So what we in our own little way are trying, because our community advisory board is fairly young, so what we try to do is, like you were mentioning, just simply explain what we did. And most of the things we do is mostly altruism, because we are not giving a treatment, we're just testing something. So we just sort of try to do that, but that's not much more.
Maybe you can get, like Ritu said, rewards and recognition. So maybe you can get the people who participated to say, I participated in this research and I made a difference.
If we do ICMR studies, maybe you can give a certificate.
So I take the point that, it should be well budgeted. And if you see the ICMR guidelines, it's very well there. 2017 guidelines talks all about post-research access and benefit sharing. But it is for us to budget it. If you don't ask ICMR for that budget, ICMR is not going to give it. So investigators need to start asking, building this into their budget.
Can I also ask you?
Asking. A lot of projects are asking, and so it's not like, we cannot generalize, yes. A lot of studies we have funded, and in fact, even payment for compensation, payment for participation, all that is now being built into the research grants, insurance. So there's a lot of things which have...
Dr. Roli Mathur, since you're here, do you have budgets for patient and public involvement early on in the research grant writing?
That is exactly what I'm trying to say, that researchers need to plan and propose that budget when they ask for funding. And I think NARI is a very good example. The research done in HIV/AIDS, where all the community engagement work, community advisory boards have been set up. There are huge, I think we have to give a clap to this institute who has really gone into the community and did a trust building process. I'm quite aware of the great work that is being done.
We do budget for workshops to be conducted and the community programs and community
somehow
engagement.
What we've done in HIV has not translated into rest of medical research or health research. So that's something that we should probably take away as well. Yeah. So
just wanted to add a few words more. What Madam was asking and what Roli Madam has already told, that ICMR guidelines has the provision. So I am attached with one Model Rural Health Research Unit, that is a scheme by the Government of India and from the DHR, Department of Health Research. And this Model Rural Health Research Unit works particularly in the chicken snake corridor of India. So those who have idea of the chicken snake corridor or Siliguri corridor, it is a small 22-kilometer stretch between Bangladesh and Nepal, sandwiched area, and it connects to the northeast with the rest of India. So recently there was a lot of hue and cry by the Bangladesh people, many of them, that we will block that chicken snake corridor and separate the northeast, something like that. So anyway, I worked there, and we had been working there, though we don't have a formal, properly developed building. We work there at the community level, and whatever study we are conducting, we provide individual level data to the patients, to the participants about we collect their blood, we do pulmonary function tests, we do number of other tests, and we always return back to them with their reports.
So I think we'll just wrap up. Thank you so much for your participation. I think we clearly have pockets of really good practices. We need to make sure that we can extend them across. And also I think, as some of the panelists said, that we need to ensure that as we push forward with patient and public involvement and partnering for research, it does not become tokenism. It is taken in its true sense, and it is always respectful. Research may not, from a patient perspective, research may not result in a cure. It may not even give us the answers we are looking for, but I think it can always be accessible, it can always be transparent, it can always be respectful. So I think that's really, as a patient, I'd like to reiterate. Thank you.
I'd just like to say that we are looking at actionable points. So the kind of experiences all of you have shared, I think, should go into making some kind of a document which allows for people to take help from, to be able to seek guidance from as to how certain challenges were addressed and what you did, some of the good practices, and that probably would be a direct result of this particular session, because I could see that you all spoke from your experience of being in the field as researchers. Thank you all very much for sharing that, and thanks to my co-chair as well.
Thank you. Thank you, everyone. I think we have enough food for thought now that we turn to the ethics committee's perspective. So I kindly request the chair, Dr. Sudha Ramalingam, and the panelists, Dr. Keshar Kunja Mohanty, Shifalika Goenka, Dr. Vikrant Bor, and Aarti Kumar, to please come up on the stage. Meanwhile, I'm sure most of us have a paper that is asking for the 3 questions that we are discussing today. If you could put in points that are not discussed during these panel discussions or when the speakers were speaking, we can gather some more output and input in that sense. Also, we also have an expert list requisite form that is given to all of you. So you can also suggest some more experts on the kind of activities that we are coming up in ICMR Bioethics Unit. So we kindly request you to fill and hand it over to one of us, and we'll be gladly having it with us. Welcome Dr. Sudha Ramalingam, and request her to please open the panel discussion. Thank you.
Yeah, thank you. Thank you, the ICMR team and also the St. John's team for giving us this opportunity and to open a dialogue on this very important topic. So we went through several perspectives. One, aligned with the theme, people-centric approach. The patients themselves were the first opening, spokespersons. Next, we have the panel discussion regarding the research, how we can include, make it more people-centric. Now, we are here with, the ethics committees. So as Ms. Ritu said, nothing about me without me. So it's a very, very profound statement. We have this in several fora. For example, the recent NMC changes mandates students to be included in the curriculum committee. So when important stakeholders are there in all areas, why not research? So it is our duty to make sure that what we do is patient-centric or people-centric. So we have several examples. In the US, for example, we have the Type 1 Diabetes Exchange Initiative, which includes patients for treating Type 1 diabetes patients, and also the DIRECT Consortium, which looks into diabetes research on patient-centered strategies of Europe. So in precision medicine for treating diabetes mellitus. So without much ado, I will just seek the opinions of our expert panelists. We have Dr. Mohanty first. Ma'am, you have extensive experience in ethics committees. So I would like you to just touch upon what are the hallmarks of people-centric research, and in your experience, what are the challenges the ethics committees face to meet with this requirement?
So at the outset, I must thank the organizer, Dr. Roli Mathur and her team, for involving me in this very important and very innovative discussions. So I also thank Dr. Sudha for inviting me to answer some questions. And actually, I am the researcher, lab researcher, and I actually, this is a new experience for us, for me, like very interesting and fascinating area also, people-centric research. So I will just touch upon some of the hallmarks, what should be the people-centric research, like treating participants well and with respect, what all we have discussions in the last 2 sessions. And caring and respectful. Researchers must ensure the caring for the participants and the respect should be given, and appreciative and thankful, and doing research that is meaningful, which can make a difference in the society, what has been discussing in the previous sessions. And that has to be there, working in the partnership, equal partnerships should be there when the research is being conducted, and participation is representative and fair from the all strata of the society. Participants should be drawn, and participation is simple and straightforward, not much complexity. Both ways they have to be very honest. So now we understand how important this people-centric research aspect should be addressed. For a successful clinical research study, equal partnership of participants is very vital, as we understood from the Mr. Ritu's presentation and Gautam's presentations. And research can be further improved by doing research in more people-centered ways. So as a member secretary of our Human Ethics Committee, what I would just put forward some few points how this can be addressed in the Ethics Committee. Like, prepare and create hallmarks and principles of good people-centric research in India, and for various local population and various regional aspects also we will have to address in that hallmarks. And then which can be referenced and available to researcher, participants and EC members to check and recommend from time to time. And there is a need to educate the researchers for good people-centric clinical research through workshops and all these things, and encourage them to provide more details in planning their studies to evidence that people-centric approaches have been incorporated in their proposals from the beginning itself. And proposal application forms and EC should include points from where it can be visible that principles and hallmarks of people-centric approach in the proposal. Experiences and feedback from the participants should be taken in between in this study, and it has to be incorporated in the annual report when the annual report is being submitted to the Ethics Committee for review. And then Ethics Committee can review this and recommend accordingly if it is not there. And a representative from patients and people to be involved in the to assess action plans in partnership with the researchers and Ethics Committee during the review process itself and during the initial phase itself. So these are the 5 aspects I think EC should adopt so that that can be addressed in the right way.
Thank you, ma'am. Are there any challenges that you would like to highlight?
Like challenges, I said researchers faces challenges like they are more concentrated about their career program and all these things. So they say they don't realize that the research is for the people only, for the participations, but for the time constraint, and they have their apprehensive of that thing. If some more people will be involved, then that might get delayed and all these things. So that has to be addressed by the EC. So by sanctioning some good people-centric research proposals, so they can demonstrate that things.
Okay, thank you. Thank you. You brought out some important points, ma'am. Thank you. Dr. Shifalika, Goenka, you have extensive experience being in an EC or establishing an EC. So in your experience, how have you incorporated patient-centric approaches? Like, can you please share your thoughts on that?
Sure. Thank you very much. And first of all, thank you very much for inviting me, Dr. Mathur. And what I want to make a general comment is I must congratulate the bioethics unit because I've seen it develop over almost 2 decades and under the leadership of Roli, because I think it started small and now it's one of the most powerful verticals of ICMR. So wishing you many, many more so that more of ethics comes into play and that has a stronger role. Okay, I'm going to be quick, hopefully. And what I'm going to be doing is I'm going to purely speak from experience. So the principles we adhere to, and interspersed with some examples, and then with specific recommendations for the ICMR checklist which you have. The first, of course, is the principle of respect dignity within the framework of equity. Now, it's very easy to talk about equity and autonomy, but coming back to what Amartya Sen said, is that autonomy is a function of the capability. And if you are vulnerable, you don't have any alternative treatments available. If you're poor or your caste issues or financial issues, you have no autonomy. So those aspects we always see in the protocol, have they been incorporated in? And taking forward from that is the informed consent and PIS. So I just wanted to make one recommendation that we have to move from just translation to a cultural translation. Because the world has, of course, moved to a cultural translation because everyone's stuck onto translation and back translation, literal word to word, and the meaning gets lost. Also, in the informed consent form, have the effects being differentiated from the benefits? Because it's very easy to talk about biochemical, physiological flex, but what's the patient going to benefit? So has that been clearly elucidated in the informed consent form? So that is another aspect within that's point 11 of the checklist. The third aspect which I wanted to say is that we also look at unnecessary visits. Are the people, because you know what, ethics committees are looking at funded proposals. We're looking at proposals which have been sanctioned and funded, and everyone's on top of us for approvals. So the other aspect is the biosamples, the biochemicals. So we have a huge discussion on the amount of blood which is being collected. Do you require 10 ml? Why can't this be done in 5 ml? Because you always have a biochemist on the committee and other experiences are talking. So that aspect has to be taken into consideration. Every ml has to be debated. So also the aspect of storage of samples. So are you planning to store the samples? Has that been mentioned in the informed consent form? And normally we have another section. So we have two signatures. If they agree, they may agree to the study and they may agree to their sample being taken, but they do not agree to storage of the samples. And what are the tests be done? We are very particular, the tests have to be declared. And if there are going to be other tests, which we don't know because science we also have a biorepository 10 years, 15 years, 20 years. So there are de-identified samples where we may do tests which have now come up, which are not there earlier. That's fine, but you need to have taken that permission. So people may agree to their being the present test, but not to store it. So that differentiation has to be there in the informed consent form. We also adapt to the precautionary principles. So certain studies, what we found, for example, pregnant women. So one of the outcomes, like we're looking at really poor pregnant women. So stillbirths. Now the normal treatment arm, you need that extra follow-up with them. They've lost a follow-up, you don't know whether there are many more stillbirths. So a lot of precautionary principles to prevent adverse outcomes. So sorry about that. So that is the point 4 of the potential benefits that needs to be addressed. And results communication is a must. However, what we do is interpretation aligned to the cultural background of the community. So that needs to be there, minimizing risk and maximizing benefits. So number 3 talks about the potential risks and harms. So I think that point about minimizing risk and maximizing benefits needs to be put in. So I think these are the key points which I wanted to mention. And of course, the most important is clinical equipoise. Last one, the first point in the ICMR checklist is the scientific design of the study. But is there clinical equipoise? Because when the science is inadequate, you are harming the patient and it becomes unethical. So clinical equipoise, I think, needs to be mentioned in the checklist. Thank you very much.
Yeah, thank you, Dr. Goenka. Several important points you brought out. Probably after the first round, we'll have a discussion. Next, Dr. Vikram. Is it feasible for ethics committees to promote community engagement and inclusivity across all types of medical research? Or are there any specific context where these approaches are more applicable? What are your thoughts?
Thank you for this question. And first of all, I would like to thank the organizers, the ICMR Bioethics Unit in particular, for inviting me to be on this panel. So while we talk about people-centric approaches and the involvement, better engagement of the participants, I think there's no dearth, or there is an intent. There's definitely an intent, and nobody really would dispute that it shouldn't be done. What we should actually focus on is how do we do it. So if you really look at it from a overall perspective, and not just looking at participants holistically, looking at the researchers as well as the ethics committees, we should be mindful of the fact where such things are easily doable and where there is a problem, and how do we go about resolving those. So when you look at public health or community-based research, there is already a scope for engaging with the community prior to doing the research, right? So there the entire approach is to be with the community, right? I mean, not that it's done everywhere, but it should be, and it's probably easier to do that. The other thing is, when you look at the other where most basic biomedical research goes on, in clinics and hospitals. Now in that's really a special case where you would have some participants come only for a certain period of time, and then they are already so overwhelmed with their own the condition, and then how do you really engage them? So though it is important, I feel the participation in the community-based research would be easier, but compared to the ones where you have observational studies, you have a single time point observations where the participants come, and then it is really a task to actually engage. So here I think the ethics committees need to go beyond what they are doing, and we need to have certain framework where we actually list down how the researchers could take care of these, because it's easy to say that it should be done, but how do you actually go about doing it? So I feel maybe documentation of the entire process, right from alongside when we create the proposal. It's also important to maybe have a checklist of what were the community engagement or the patient engagement efforts which have been taken right from participation. So this is not to right now it cannot be made mandatory, but it's good to document and then learn from these practices. So has there been any effort to engage with the patients? May not be the same patients who are actually going to be part of your research, but a similar research patient group, and then learning from them. And of course, all that has been said about patient advocacy and patient involvement in the ethics committees while the project is being discussed is very, very important. But also continued oversight and monitoring, which is very, very important. Site monitoring is part of the ICMR ethics guideline, but how much is it being done? It's very, very important that we really follow up and give this aspect a very important. We treat it importantly. Otherwise, it will just remain on paper. Like the ethics committees do have an important role, and also I would like to highlight over here the ethics committees are have to maintain a delicate balance between facilitating research and being regulatory. So it's not an easy task, but I think there should be a better framework created for points that need to be taken up. I think that will go a long way in implementing what we are talking about. Thank you.
Excellent points. Thank you, Dr. Vikram, for bringing very important points. Dr. Aarti, so if ethics is more than compliance, how can ethics committees be reimagined as ethical stewards, guiding institutions towards people centricity and public trust in science?
Thank you so much, Dr. Sudha, and thank you so much, Dr. Rowley, and to ICMR. And I think I echo the sentiments of everyone here. I think we are really laying out the vision for what research should be, and that's extraordinary. when we look at ethical committees, and we must remember the way they came up was because there was exploitation, right? And so the origin is actually safeguarding the rights, the basic rights of patients. And from there, when we are talking about people centricity, we are truly, as our patient advocates in the beginning, they talked about, how can patients be actually partners, right? Not just subjects, but equal partners in the research. And I think that's a very, very deep question. Well, I wanted to actually start from, what Dr. Jesani said right at the very beginning. He said social science, we talk a lot, we've debated a lot on ethics and everything, but, in medicine, it's not as much. And, I reflected upon it and I was thinking about, some instances, so I don't come from a clinical background, but when I can call myself many times, I'm a researcher, but I speak on behalf of mothers and babies a lot of the time. And, when I see, for example, young residents, of course, they need to practice, but, they have to do a per-vaginal exam. I don't see consent being taken, right? Everybody is just doing it. And I just think of I myself feel violated, actually. When I see our neonatologists, for example, I see that paradigm of, this mother is dirty. We shouldn't have her, if she's going to endanger the life of her own newborn if we, bring her into the unit. So I think there is something in the medical culture itself that is anti-people-centric, that infantilizes patients. And when I was doing some deep reflection, actually, because I don't have a lot of background in participating in ethics committees as such. I did design, for our own ethics committee, the initial, the charter and everything. So that's my background. But I was reflecting deeply as to what ethics committees can do, actually. But in that reflection, I realized, the damage is done much earlier. When we talk about clinical research and health research, I think we need to actually incorporate these ethical principles. And how do we see the patient? How do we treat our patients? Very, very core to our medical education in the first place. Research actually comes much later. The ethics committees are actually right at the end. They are just a checkpoint. So much the worldview of the researcher has already been formed. We also live in a certain social environment where we see such kind of infantilization happening. So, a lot of things need to be done upfront. But yet, as Dr. Bhore also pointed out, and as several of my colleagues pointed out, there's a lot that ethics committees can still do. And I think very rightly pointed out that we need to put in frameworks in place to really be able to make this happen. When we talk about partnership, I think it really begins with respect. How can we encode respect? How can we talk about, and when we talk about reciprocity, right? I'll give you just a small incident, and we're not just talking about the principal investigators or the researchers. When we do community-based research, it's also the data collectors who go in, and how are they embodying those principles. So for example, we heard our data collectors say, when I go to the mother, she asks me, why have you, what are you going to give me? So when they complain about that, and I was like, okay, that means that she's seeing you as, she's not seeing you as, bringing any value to her. So, so that questions, right? So how are we engaging, even when we are going in the family, it's a more equal relationship than when somebody comes to a hospital, but still, how are we engaging with them to truly make them feel, involved and respected? So when we come to frameworks, I was thinking along those lines of, okay, our ethical committees, when we are reframing the purpose, from safeguarding rights to people centricity, we need to frame the purpose of the, even the ethics committees. How are we framing the purpose? Does it involve any structural changes that we need to make in the design, in the composition of the ethics committee? What do we need to put in place in terms of, the methods and protocols that we need to put in place? And in that, for example, what should be the guidance to the researcher? Like when we talk about inclusion in the beginning, like what does that mean? How, for example, during their pilot, how are they involving, how are they engaging with patients to make sure that they feel respected and included? Ethical oversight, they can provide oversight in terms of whether the results are being disseminated in a way that communities are able to, they are involved and they can take action based on the results, etc. So, and also, how can we include reflexivity? Because when I see ethics committees, they're very busy people. It ends up being just a compliance exercise. So how do we encourage more reflexivity in thinking? I think that's just a question to everyone. So thank you. Sorry for exceeding my time, but a lot that I wanted to share. Thank you.
Yeah, thank you so much. The floor is open for questions. So before that, I just have one question myself. So all of you brought out very important points. The basic, thread is like, the ethics committee's important role on making the research people-centric. On that note, is there any unique challenge that we will be facing in the Indian context, given the situation? Like vulnerabilities are very diverse, different forms, like, student, teacher, pregnant mothers, like so many vulnerabilities and vulnerable situations we see in the population. So how do you think in the Indian context we can make it more people-centric? What are your thoughts? Anybody? Yeah.
So my raw thoughts, I think we need to move. Right now we were talking about, Dr. Roli and I were talking about it. Ethics right now is just seen as a compliance function, right? It is not it is there in letter but not there in spirit. So I think we need to do some more, these kind of conversations that we are having today, we need to do it more widely, broadly. I see, I'm sure this is a big event, but very few, even from the participation itself, one feels that, okay, is this of interest yet or not, right? So I think how do we engage, how do we generate interest in the first place, how do we start more dialogue, we need to bring it more in terms of the spirit, embody those principles. We need to create more forums for that. So just some initial thoughts.
Very well said. I think there needs to be more equity. Right now, when we talk about research, it is heavily, researcher based, and we never engage to that extent. Even when we talk about dissemination, so everything has to be. So the point is, there is definitely a need. How do we engage and how do we go about? So in our context, as you mentioned, is it difficult? So I would say yes. In the Indian context, it is difficult because there's so much. What do you say? I don't know whether it's right to use entitlement. So when we talk about medical fraternity as such, we are always seen as more entitled, and the patient is always at the other receiving end. So you choose to give information as and when you want, not as the need is. So I think that needs to change. The power equation needs to change completely. Only then, I think. So right now, I think the odds are heavily against the patients. So unless we change the mindset, I don't think anything is possible.
I would like to just one point. Actually, this to make it a people-centric research, it has to be across the ecosystem of research, not totally. From the funding part, from researcher part, from the pupils part. So education and public education, somebody told in the morning, that is very important. And I am just giving an example that there is a study going on DLSS survey for tuberculosis, NIRT initiated, and it is all across the country. And there we see that people are very much participating in the research here. And we do the blood testing and all these things, and immediate report we are giving. So these people are very happy and coming and participating in the research. So that type of some education to the researcher and to the public, that is very much necessary.
So I think it's multi-perspective. We need to address this from multiple perspectives, top-down as well as bottom-up. Top-down is the funders' perspective. So a lot of international funders have made it mandatory to be people-centric. co-designing, involvement right from the beginning, and they want to see that prior work before you can even submit your proposal. So that is, I think more and more funders need to take care of that. And even for regarding the dissemination of results, they're very particular. So that from bottom up, so what I'd say is that informed consent needs to be converted to understood consent, and the sensitivity to empathy. So because you have so many vulnerabilities for equity, and the third most important point is sticking to the Hippocrates oath. You cannot be moving over it in the justification of global science. No, and there are ways to do it. Thank you.
Thank you.
Thank you. Just finally, I just wanted to just emphasize on, this point, and Dr. Bhore also said it. I think physicians, this profession is probably the only one that has supreme power of somebody else's body and their dignity. And I think that needs to truly be recognized. And a lot of deep thought needs to go into the ethics of our conduct.
Just a quick question as a patient advocate, if I may ask the panel. If I am seeking to be, participant or a member, or just a very, layman, participant in the research or doing any, kind of a contribution, who should be? So, two questions further. Who is the responsible person giving the authority for that patient or the patient advocate to come and be part of it? Who is the responsible person? Is it the principal, who is running that research, or or is there any team member in the research team who is deciding that, okay, we should take that person, or we should take X number of, patients to be part of the team? Or is it any member of the ethics committee member who decide, you should do it? So who, approves that participation? One is that question. Second is, if I am already being part of, multiple research of a clinical trials or any, observational study or any other study, who should I seek, as a guiding light or a mentor to guide me to understand, because recently I was working one of my tobacco study, the tobacco awareness study in the cancer survivors in India. And I was told that you need to, do some certification course, and you should have that certificate. I don't remember that because that attached to some terminology. And again, come to it because I didn't know that, and I was completing all the ethical documentation part. And that's what I know कि आप क्या sequence में चाहिए होता है to approve us research in a ethical committee. And you are right on that note that it comes to a point when it is a compliance, look at the compliance level issue, that you have to be on point in everything, that you have to submit the edits again, saying. So I learned all of them, but who will guide me? Who will tell me that these are the steps you need to do, or these are the professional certification? If you do it, that will elevate your role as a patient advocate or a patient in the research team, or when I am representing research at an international or national level, then I can mention that I am certified a researcher. Or are there any further, if I am being part of X number of studies already, so can I look at as a career option, or are there any opportunities in the health sector for me, because I am being into health, supporting my cause, and there are fellow survivors also in my team who have been part of the research, execution team, and also have participated as a we called as a samples, right? So they have already participated, and they have also contributed while serving the, taking the collection of the data, or putting out the information in the Excel sheet, collating all the data, and doing little bit analysis, etc., etc. but what kind of, how I can further, so just help me to understand this thing.
I think it's very insightful. It's really wonderful to have somebody, like you represent the entire participant and the patient community. And I'll just attempt to answer your questions. Regarding the first question, who will give you the permission? So right now, I don't know whether there really exists any guideline or a framework which will which talks about this. But it could even be the principal investigator of the research which is being conducted. So if you as a patient, you come in contact with someone or they come in contact with you, you can very well be, that's what we've been talking about, like co-designing and inclusion of the patients and the patient advocates in our research. So that I don't think really requires permission as such. You could be, a part of the team. You could be a co-investigator. I mean, it's also important to recognize that patients and patient advocates can also be co-investigators in research because they have a stake in research. They have a stake in the findings, the benefits. So I think it could be that. So regarding your second question, who would give you the guidance? So now here I'm a little bit confused. So you would want to engage as a researcher because what you pointed out points more to the fact that you would like to be conducting the research. So if you want to be a researcher and conduct the research as a patient advocate and a researcher, so that those are very well outlined in the ICMR guidelines. So what are the regulations and what are the needs and eligibility of a researcher? So that is very well pointed out.
Sorry, can I interrupt?
Yeah, sure. Yeah.
The question is, as a patient-led research,
okay,
is very different from what you may know how to do research. You see Ritu, you see me, I do a lot, I participate in lots of papers, but I'm not a researcher, I'm not a scientist. Right, so there's a very different way for us to think about this is something that should be published, but at the same time, yesterday I was talking to someone, I've done a paper on the retinoblastoma work that I have done, and I was told, okay, fine, maybe we'll get you a guest editorial, but I'll write it for you. I said, no, you don't need to write it for me, I'd like to write it myself, but obviously I'm not a researcher, I'm not a scientist, I'm not a doctor, but I've done a lot of work on this. So how do I do this, right? And so the question is really that in the country, like at CanKids, we have this PACER project. We try to build up patient advocates. We encourage them to, we even put them through GCP trainings and all of these trainings ourselves. But ours is a very small initiative. How do you make someone who's a patient advocate who wants to do research or patient-led research, how does that happen? That was the question. That was the question she was asking. And that's important because many people will say, oh, I'd like to participate, but I don't need to become a scientist or a full-fledged researcher to apply at ICMR to be a researcher. ICMR will always disqualify me. As a patient, if I wanted to do patient-led research, I don't know how to fulfill those guidelines at all. I won't qualify. That was the question.
So, would you like to?
No, I just wanted to, I think you want that space to be created. I think you are very much articulated
Absolutely.
a need that right now there's nothing there for it, but you are advocating and I think everybody would buy it that
Absolutely.
space needs to be created. And similarly on ethics committees, you have this layperson, right? I've been on 2 or 3, right? My first ethics committee experience for many years was fantastic because the chair of our ethics committee was Dr. Ganguly. Every time we would start the session, I had Dr. Shama Chona and me, we were the lay scientists. She would say, अच्छा डॉक्टर साहब आप लोग सुनो, आज जो हम करने जा रहे हैं उसमें ये aspect है, ये study है. First he would explain the study to us in our language because obviously we didn't understand the studies half the time. Then he would say, okay, now you think from the patient's point of view, and then he would give us time.
Now, because both Shama and I are women in our own right, we knew how to stop the discussion and say, Dr. Ganguly, wait, we want to make our point. Otherwise, most of the time, the layperson is petrified to open their mouth in the ethics committee because there are all these doctors, all the scientists, all the researchers busy discussing things which we may not necessarily understand. So that was also a big piece of it, that yes, ICMR can create all the stipulations. Funders can say, please make sure you have patient representatives in your research papers, etc., or in your study. But what is that? Is it meaningful? You just talked about lip service. A lot of the time I feel it's lip service.
The concept of plain language summaries is now extremely prevalent. It's mandatory in a lot of countries. We do not yet have it. And to the point of Dr. Jesani saying how do we make, or Dr. Durga saying that how do we make research accessible to the layperson, we need to start with plain language summaries of every research. It should be on the CTRI site, it should be anywhere that any research paper is there should be a link to plain language summaries. That is a start that has to happen. And patient advocates and trained patient researchers can help write those or review those plain language summaries as well. To the point that Poonam was making about feeling empowered to speak in any committee, whether it's an ethics committee, whether it's a research group, that's something that I think we'll all have to work towards, to create that space to step, for the researchers to take a step back and to recognize that there's value when we have patients giving critical inputs, and for patients to feel empowered that they can make a statement. And again, for that, it's important that the discussions happen in plain language so that it's accessible to everybody.
Just like to make one point. I think as Dr. Aarti has also emphasized, you probably, Ms. Ritu, are, and Ms. Poonam, you are, unique in your own way, that you really want to participate and really contribute in the way that you would like to go about. So I think what you should also consider yourself as grassroots researchers. You are researchers. There's no denying from the fact, because what you would do would definitely add value to what is being done. So I mean, though maybe you may not have the same kind of background and the eligibility criteria, but that doesn't prevent you from being researchers. I think in your own right, you are researchers. The fact that you've published.
Pardon, it should not be unique. It should be prevalent across the country.
Absolutely.
And it is not unique. And it is not unique.
Say I'd like to participate, and it should be easy for me to participate in a research design or in an ethics committee, etc. We have worked very hard in my NGO, but we have one NGO, and therefore we look unique. It shouldn't be unique.
No, and it is
not. To set an example. See, I think there is more need to talk more about and highlight what you're doing, because how would anyone know that this is also a part to be taken? So though you're unique now, I think that it will become a norm.
That's the purpose of
absolutely. That should become a norm. So we need to highlight more such examples.
How do we create a framework that people across the country, somebody who's on a cab says, okay, I'd also like to participate in this. Where else is there a study that I could be part of a research design? How do I access that information to say, I want to participate in an ethics committee? This was Ritu's question, that if I want to participate, where do I access this information from? I just feel like participating in an ethics committee or in a research study on people-centered care. How will I find this information? How do I get to know where it exists?
So
I think those are very valid points, and I think we need much more bigger voice for ethics all over. And I think we call upon researchers and ethics committees to really not be those, the way the monotonously do their research, but to become, come out and even for you to disseminate. And I think a lot of us should start writing papers. If you look at the literature getting out from India, we have hardly, not much at all about all the various smaller initiatives. We should create a voice, a movement in the country.
So research is all about being in a team. So I can't do a research in silo. If I have to do a highly specialized research, I partner with the concerned specialty. So similarly, you can take a lead and bring research questions and approach the team of researchers, which I'm sure all of us will be ready to help and disseminate that. But
ICMR could do a survey on all the lay people of ethics committees to say how do you feel it.
Actually, we did a study when Dr.
Why ICMR should do?
Yeah.
You can do anything.
Actually, we did a.
Why should ICMR?
Actually, we did a study.
I think ICMR is not required to find it through a study, because there are many people, there will be a lot of conflicts. I understand that many people, they have lost their laity long back.
Yeah.
But still they are participating as a lay person. Lost their laity because they gained a lot of experiences after spending so many years in the ethics committees.
Yeah.
So they no longer are lay people.
Dr. Oli, if you remember, when Dr. Vasanta was there, we did a study among the different ethics committees across the country, how lay people, what do they need and how do they perceive? Are their voices
FERCI had done that.
FERCI,
we did a training program also.
No, the curriculum was developed by FERCI. The study was done at PSG. Me and Dr. Vasanta did it. And FERCI did a lot of training programs only for lay people. So probably we can take up that again and, we can continue that. Yes, make it more, accessible and we can do it. Yeah.
Because I think even ICMR has done a lot of work on people-centered and people-centric approaches and many different initiatives. So
exactly.
If I check with AI, it promptly tells me how many things you have done. But if I go and ask people, they say, oh, we didn't know any of this. So that's what I'm saying. Disseminating this information then is important.
Yeah, probably we have to collate all the discussions what has happened today and make it a resourceful document so all of us can access and benefit from it. I think it had been a wonderful evening. Is there any question? One more question and then.
It's again Amir Khan from Sochara, and I'm one of the conveners for the People's Health Movement of India. And I come from a school of thought how do you politicize the research? And research for the people. Not writing papers, not to present in academic kind of conferences, and though it's necessary, but how do you make research for the people? And in our experiment, we have done a lot of experiments and a lot of exercises in Tamil Nadu. And in our one of the experiment, the exit survey, which the previous panelist was talking about, we just did a simple exit survey. The people who come out of the PHC and the hospital, government hospital, will given 2 chits, one red and one green. They will just put, if they feel good, the service is good, they will put green, and the service is bad, they will put red. And then the entire PHC team, or the doctor's team, along with the elected representatives, including MLA, they all become a researcher. They all sit together with a patient and they start probing why they put red, why they put green. So that gives a beautiful kind of output and a kind of healthy competition among the health system staff to improve the output of the services. So everybody became a researcher, including MLA. So that I think the country needs that kind of a research. That's at least for us, to accent research and kind of how maximize the space for the people to take part and lead the research. And that's where, and the language plays important role. I think she was talking about language. We know Tamil Nadu government has just nip down a DLHS survey just for one single word of from pentavalent to Muttadapusi, that's pentavalent to DPT. When the ICMR found and when the DLHS found that the vaccination coverage has been come down from 89 to 54%, Tamil Nadu government rejected in the saying that you didn't ask a proper question. What was the question? That time Tamil Nadu government introduced pentavalent from DPT. So government rejected no, you didn't ask the proper question of Muttadapusi or Anjitadapusi in Tamil. It's the only word they used. They just nipped down the entire research just for one single word. So that means the language and the kind of spaces and the kind of framework which we set for everybody to take part in research and everybody to become a researcher. Then the action will take part and the solution will come out.
Thank you again, Dr. Oli and her team and St. John's team for having given this platform to discuss these important points. Thank you, panelists, for your wonderful insights.
So, with that, we'll move on to the next session, which is summarization and way forward. May I please request Ms. Poonam Bagai to join us on the dais to present her views. May I also please request Professor Shalini Bharat and Dr. Sudha Ramlingam to join us on the dais for summarizing the panel discussions. Ms. Poonam Bagai, you can please address the audience and summarize session 1, which was patients or people's perspectives. Thank you.
Yeah, thank you. Thank you so much. Thank you, Dr. Rowley and the ICMR team for organizing this. I think it's very, very important from our point of view as patient advocates. And so the first session was from two patient advocates, and I think that's always, for me personally, a big step forward when you place not just the patient in the center, but the patient up front. And I think that is increasingly something that I see in the 20 years that I've now been doing this work as a patient advocate. Increasingly, there is a respect and a recognition for that. There is also a patience. And I first saw this when Ritu spoke at one of the WHO meetings. And for the next 2 days, everybody only spoke about Ritu, because what she had to say was important and people were listening. So I think that first session was important in that sense because it was simple. It was what mattered to Ritu herself or to Gautam about, and it'll stay with me that what he does is because his children had sickle cell disease. So his experience is very real, and that real makes a big difference. And I think, therefore, that, for patients or patient advocates anywhere in the world, that becomes important, that their voice is being heard. So that's step one. And then I think the rest of the sessions, and I'll hand over to you as well, but a couple of the things that mattered to us was, is there a framework on a more national level? And that has been one of the asks. And that was the thread also through the session, that while there is a lot of good work that is going on, there are the ethics committees, I see what ICMR is doing, but is it actually something that makes it easy for the patient? It shouldn't become lip service. It shouldn't be, as you said, the layperson is no longer the layperson. Is it easy? Is Ritu the confident person who can stand here and talk? Or are there as you said, the illiterate person? He also cares what happens to him. So I think that is important. One of our requests has been to Dr. Rowley as well, that, the CTRI website actually, can we have off of that, a whole patient platform that allows me, and this is something I have felt, that if I'm a parent who has a child with Hodgkin's lymphoma, how do I find out where in the whole country is there a research study going on where I can maybe take my child to participate, because we know that it could be better led research. So I think there have been some very good ideas that have come up today, some very good points of view. And I think they could be built together to make it much more about the people and for the people. I really like the session by the researchers as well, because they are engaging with communities and with community advisory boards, etc. So to capture that from across the country, to be able to say, okay, is it something that my community advisory board told me, not something that I think as a researcher, but did I listen to my parents or my patients or the community board say this? And the one piece that I definitely want to say, Dr. Rowley, to you and to the others in this room, is that when we say that now in a lot of the studies, the patient should be there for research design, or the patient should be there, or the lip person should be there for, in an ethics committee, what does that actually mean? And can we actually make sure that happens? And actually it will only happen when we start educating and empowering the patient to be able to do so. And I can only tell you this, that at CanKids, even whatever we do, we first have a focus group discussion. And the people who participate in the focus group discussion are the mothers and the survivors and the patients, and we listen to them. And I think that is something that I find a little bit missing, that we're not actually enabling people forums or focus group discussions, or asking lay people, come sit and talk and tell us what you think? What are the priorities? Like, one of the things we'd like to be perhaps be able to do is to say, okay, what is it that people want researched? Have we done a needs assessment by, to say what are people wanting researched? Or is it a researcher who's deciding or an institution who's deciding? So I'm sorry, I've added two parts of it. One is trying to summarize what the sessions were from a very patient advocate point of view or a patient point of view. And also at the same time, our own asks for a few of the things. Over to you.
Thank you. I didn't realize I was going to be here again on the stage, but reflecting on, the session that was about researchers and how do they engage, actually how do they operationalize the whole people-centric approach. Because sometimes these are, very catchwords. Involve them, engage with them, do more patient-centric research, listen to the voices. But as you heard from the 4 panelists, there are quite a few challenges. And there are no set answers, I think. You cannot really bring out a cookbook kind of a thing, do this. Because the challenges will be as complicated as are the researchers that they are, dealing with. And the kind of participants that they are, engaging with. So, but there are, I'm sure there are some overarching principles, or there are some unifying principles, or guidelines that one can follow. And I would think that all the 4 panelists in that particular session spoke from their experience, and one can see that there were certain threads one can identify. For example, Dr. Manisha, what she spoke about, and I think it would reverberate with everyone, is that how do you win the trust of the community and the people, that what you are doing is for the larger benefit of people. So as somebody said, when my researcher goes, or when my research assistant goes to the people, they say, what is there in it for us? What are you giving us back? This is a challenge I think every researcher goes through. So how do you say that it might not benefit you individually, but it is going to benefit the larger community of which you are a member? Say, for example, cancer survivors or people with certain difficult conditions, because no research answers an individual's issue, but yes, it is for the larger benefit. But how do you create that trust that what you are doing is going to be used for the larger benefit? I think it's a very important thing. So how do we do this? And HIV research, I must say, being from the field, I think has been a leader in showing the way. So maybe at some point in time we should collect all the experiences that some of us as researchers have gained from the HIV field and share it with others. One of the second points that many people talked about, and Dr. Naro talked about, was that CAB's role in creating that that trust. It is also about this, that how do you bring people in, how do you make sure that there is no politicization, or that there is dispelling misconceptions and myths about, for example, vaccines and so on. There can be many things which just go like a wildfire in the community, and that will be the end of your research, So the role of CABs, I think, again, very practical hints. Also talking about, Dr. Mukhopadhyay talked about, how in many of the medical colleges, this may not be as part of their education curriculum, but where it is, I think doctors are able to follow that in their practice, and to be able to see that the communities are the end beneficiaries and not just individuals and so on. So from your acronyms, one could understand that there is so much thought, given to, the way you would think that people centricity should be brought into focus. Dr. Ananya talked about, I think from the angle of, grassroots research, really where we have to see how to not use certain slogans as tokenistic, you know, in actually operationalizing people-centric research is not easy. And you can never say, you know, what are the kind of challenges that may, you know, confront a researcher. That is only to be experienced. So at the end, what I felt was that the researcher's job seems like, you know, the researchers have been put on a pedestal and they need to come down. They need to climb down from the pedestal to be able to think that, okay, you are one type of researcher. Because we heard from everyone that there is so much interest in being part of a research, in contributing, in playing a certain role. And there are different types of researchers. So there is nothing, you know, that there is only one type of research and experts with PhDs and only those can do. So this is something which we have to acknowledge as researchers. So we need to climb down. But at the same, and we need to democratize. But at the same time, I think some capacity building, because patient advocates are here telling that, you know, they want to. How do they do it? So there has to be, I think, some kind of a, Dr. Rowley, some kind of a, you know, certificate program, some kind of a short curriculum has to be developed for lay people to get engaged, you know, have engagement with research, be part of some kind of a research endeavor, be able to, you know, write proposals which cater to a certain, you know, niche kind of communities, and be able to communicate in lay language, in regional languages, in vernacular, you know, medium, which definitely will go a long way in creating not just, you know, information, but also interest among lay people. And I think ethics bodies can do a little more to, you know, reach out to lay people to become part of their entire endeavor. So this is what I could, you know, just gather. And of course, empowering people for their role in patient-centric or people-centric research. Thank you.
Thank you. Yeah, regarding the ethics committee's approach, several good points emerged, but I see a commonality between all three, the capacity building, which is coming again and again, and the need for framework. You know, that is a major need here. Dr. Mohanty also spoke about the training of researchers as also the ethics committee members to look at the people centricity in the proposals. And also she said to get feedback and look at the experience from the participant perspective in between the study. The ethics committee can take on that lead, and then when they are doing monitoring, they can also look at the feedback from the participants. Dr. Goenka, she said the importance of a checklist and how respecting the team is very important and vulnerabilities should be addressed. And she used a very interesting word like translational to cultural translation. So cultural competency is the buzzword now among educators, researchers, and also ethics committees. So I think it is important to call it as a cultural translation rather than just the translational research. And also more clarity on benefits should be there. The ethics committee should emphasize on that. And she also touched upon the reuse of collection of biosamples, the volume and the reuse. It should be clearly communicated to the patients and the participants. And she mentioned to have clinical equipoise in the checklist in the ICMR guideline. And Dr. Vikram emphasized on equity and also again checklist, which also emphasizes on the patient-centric approach. And he talked upon the community-based research where more documentation and interaction is possible. And Dr. Aarti, she used the word patients as partners, right? That's a very nicely put. So any research patients or participants should be partners. And she also emphasized the need to begin this early. So from a community medicine, as a physician of community medicine, I talk about primordial prevention. So this should be included in the medical education, in the undergraduate curriculum as such is what I feel. The patient-centric or people-centric approaches, that is where it starts. And also, the purpose of research should be clearly mentioned and the reflexivity should be addressed. And a very interesting point from Dr. Aarti is ethics committee review should not be a tick mark exercise. It should be not just looking at the compliance, it should go way beyond that, which we all endorse. Yeah, that was a very interesting and engaging discussion, more questions than answers. I think we all go back with a lot of thoughts on that, and my own 2 cents on it. As a director of research, what I see is mainly from the academia perspective, research is being done only for promotions or rankings, so mostly. So that is a very sad state of affair, but which I don't personally endorse. But when we look at these NAC guidelines or NIR of any ranking guidelines, it gives importance to the impact factor and the H index and all numbers, but nothing talks about the patients or participants benefit or the community benefit. I think that should be given more emphasis from an academic point of view, and the ICMR guideline also should emphasize how the results are being disseminated. We have to map the guideline and see where all we can include patient or people centricity, and then we should have it. Even in the application form, it should be made mandatory, is my thought on that. And thank you.
I just like to say one last thing at the end, and this is an ask actually from us, whether we can discuss the possibility of a national framework on patient engagement and patient-centric approaches in health research. And that would cover governance and policy, which is mandating patient representation. Some of it is there in different places. So it's something that we could work with you on if you would permit. I'm sure Aparna would like to work on it as well. So dedicated funding streams is something we've not talked about, but would you be able to create a small part which says, okay, this is patient-led research? If you say who has done patient-led research in India, you can't find anything anywhere, right? I mean, even if you Google it. So that standardizing guidelines and accountability, building capacities. So what is the curriculum? You mentioned the certification. What about co-design and co-production? How do we work on those aspects? And then obviously the standard is ethics, consent, and oversight. The data and digital infrastructure piece, if that can be come into it. So there are different pillars, and we could work on actually creating the framework. And that's just a proposal from our side. Thank you very much.
Thank you so much to all the dignitaries on the dais.
We have today explored pathways to build more inclusive research frameworks and ensuring ethical and equitable participation, strengthening community engagement, and finding out ways of translating the scientific findings into tangible benefits for individuals and populations. And therefore, this shift from researcher-driven to partnership-driven inquiry presents a transformational shift in how we understand health, illness, and care. So let us carry forward this momentum. We've heard some great buzzwords today: research in people's hand, community-led research, budget for dissemination, cultural translation of informed consent form, framework for ethics committees, framework for researchers, and then co-designing and understood informed consent, empathy, research for the people, partners, and so many others. So thank you all once again so much for your dedication, your passion, your openness, and for your sharing your thoughts with us today. And together we can ensure that science does not just advance knowledge, but it advances lives. So thank you all once again, and bye-bye. Safe travels to all of you who have come from outside, and let us stay connected. And of course, you can continue the conference. We are closing this session, but I see Dr. Manjulika. I'd like to thank her for giving us this platform and to be a knowledge partner with St. John's Academy to hold this session. Thank you, and your team as well, for all the logistics and other arrangements. Thank you. And of course, my colleagues from Bioethics Unit, a big clap for all of you. Thank you.